G'day everybody. My name is Patrick Auger. I'm a practicing critical care paramedic out of Ottawa, Ontario, Canada, primarily working on a rotowing helicopter. I'm involved in retrieval medicine. Today we're going to be discussing or reviewing pediatric refractory status epilepticus, and I'm going to try and correlate it to the work context of a CCP. So most recently, the Canadian Pediatric Society published an updated position statement on the emergency management of pediatric patients with convulsive status epilepticus, and it really replaced their previous position statement from 2011. The set of guidelines are aimed at infants greater than 1 month of age and includes new treatment algorithms based on updated evidence. So I think it's important to look at these definitions because we're involved in our program in retrieving patients from across the province from sending physicians, and they'll quite often refer to these set of guidelines and they'll be following them. So the Canadian Pediatric Society defines status epilepticus as continuous generalized tonic-clonic seizure activity with loss of consciousness for greater than 30 minutes or two or more seizures with no return to baseline mental status. They also identify early status epilepticus where you have seizure activity for 5 minutes without full recovery of consciousness between seizures. And then finally, they define refractory status epilepticus is status epilepticus despite the administration of two parental anti-seizure medications. So status epilepticus is a common neurological emergency in children and has a mortality anywhere between 2 and 4%. A recent meta-analysis which reviewed the existing literature on mortality reported an overall mortality of 3.6%. And the incident with age is bimodal, with the highest incident in adults over 50 years of age and children less than 10 years of age. I think we can recognize that this situation is resource consuming, with many patients requiring transport to tertiary level care, which is where we come in place as CCPs. And then refractory status epilepticus, these patients often require additional boluses of anticonvulsants. And certainly for transport, they're often intubated and mechanically ventilated. And they're basically put into a medically induced coma with continuous infusions of midazolam and or propofol. There's a number of common etiologies along the left here, such as CNS infections, anoxic injury. There's metabolic derangements, which can include hypoglycemia, hyperglycemia, hyponatremia, and hypocalcemia. You might have somebody involved in a traumatic brain injury. There might be a mix-up with the patient's medications, or they could have prolonged febrile convulsions. There is a recognized new onset of refractory status epilepticus in children. And there was a single center retrospective study that was conducted from 2004 through to 2017 at a tertiary care children's hospital. And they looked at patients from 1 month to 21 years of age. And the study was conducted at the University of Texas, Southwestern Medical Center, and the Children's Medical Center. And when they looked at this, they enrolled 674 patients. They identified 4 patients with NORSE. And the most common etiology was viral at 20%. But what's interesting is 58% of these patients did not have an identifiable etiology. So when we look at the pathophysiology of this, certainly in animal studies, and this is different than human studies, where they've allowed patients to seize, within the first 20 to 40 minutes, homeostatic mechanisms are maintained, after which blood pressure, cerebral perfusion pressure, brain oxygenation, and glycemic levels decrease. As the patient continues to seize, they'll hypoventilate, they'll become hypoxic, they may develop pulmonary edema, which will lead to respiratory acidosis and worsen the lactic acidosis. And the repetitiveness of the muscular contraction can lead to rhabdomyolysis, hyperthermia, and electrolyte imbalance. And so this is in animal studies, but if you look over to the right here and you start to look at human studies, it does bear out some similarities. And so in a series of 17 patients, norepinephrine increased 12 times above normal, so these are norepi levels, and epinephrine levels increased by 40 times above normal. In a series of 98 patients, 70 patients had arterial blood gases measured while they weren't on a ventilator. 10 of those patients had a normal pH, one was alkalinic, but 59 of the 70 patients were in acidosis. And 23 of these patients actually had significant acidosis where their pH was less than 77, and 90 of the patients all experienced hyperthermia. And so I think the human studies suggest that what's happening in the animal studies is similar from a pathophysiologic standpoint. One of the things that comes up that I found interesting is how the neurotransmitter receptor changes. And so there were two different groups in 2005 that discovered GABA A receptors essentially internalize and decrease their density in the synapse with prolonged seizure activity. The longer the seizure activity, the more GABA receptors are internalized, which is associated with a reduction in response to GABA inhibition. And really, this might explain the reduction of response to benzodiazepines. And what's interestingly is at the same time as the seizure is prolonged, NMDA receptors accumulate in the synapse during prolonged seizures. And NMDA receptors appear to relocate from the cell interior to the synaptic membrane. And so what's interesting is in animal models, a combination of benzodiazepine with ketamine was actually more effective and less toxic than benzodiazepine monotherapy. And so these combinations aim to leverage ketamine's NMDA antagonism. And it is also sort of suggestive within the literature, I think, why ketamine is increasingly being looked at in refractory status epilepticus. So I want to just outline a few issues around pathophysiology and the clinical relevance. And so the first issue is we know that as seizures progress, there's a progressive decrease in inhibitory transmission, as I mentioned before, due to the internalization of GABA subtype A receptors. And so, the clinical relevance here is it can contribute to drug resistance to benzodiazepines and other GABA positive modulators, such as phenobarbital. And so you might want to look at early use of second-line medications such as phenytoin or phenobarbital. We want to know that, in animal studies, there's a 20-fold decrease in the response to diazepam after 30 minutes. And so the clinical relevance here within our clinical practice guidelines is this may require the use of benzodiazepine infusions such as midazolam or other second-line agents. And the causes of excitatory receptors such as NMDA and AMPA, really look at and consider the clinical relevance here is the treatment with an NMDA receptor antagonist, such as ketamine, may be required. But I think there's still quite a bit more research that needs to be done on that, and I'll come back to that in a couple of minutes. So along with pathophysiology, seizures cause blood pressure, heart rate, glucose levels to increase to maintain metabolic requirements. And so the clinical relevance is we want to ensure that we're providing good supportive care, so airway management, providing supplemental oxygen, and we're checking for immediate correctable causes such as hypoglycemia. So simple glucose check is important. After about 30 minutes, anaerobic metabolism leads to lactic acidosis and electrolyte imbalance. So we want to remember that we do carry an iStat device, and it's important to monitor and maintain electrolytes. But clinically, second-line anticonvulsants may lead to both CNS and respiratory depression. If we're getting into that 30-minute mark, patients may require intubation, mechanical ventilation. And then as the patient continues to seize, we recognize that cerebral vasoconstriction due to cardiovascular changes during convulsions can lead to a state of generalized brain hypoxia. So we want to make sure that on these patients that are intubated and mechanically ventilated, that post-intubation assessment of arterial and venous blood gases can aid in the management of these patients in terms of how you're setting up the vent. Now, the clinical presentation of this, I think you can really correlate to the pathophysiologic changes. So, we're expecting these patients on our end to have generalized seizure activity that involves both hemispheres of the brain. There'll be in tonic-clonic seizure activity is the most common presentation, with the tonic phase where the muscles tense up and the clonic phase where the muscles then contract and relax. And over to the right here, as mentioned, you can expect certainly in the early phase heart rate, blood pressure to increase. But as you get along in the pathophysiologic process and the patient starts to decompensate, you may see pulse oximetry decrease, level of mentation decrease, of course, and with the kicking in of anaerobic metabolism, if you're doing a venous pH or capillary pH, as we do using our iStat device, you may be able to identify lactic acidosis, hypoglycemia, and other electrolyte derangements. And there certainly is the potential of airway compromise. And there's potential for airway compromise not only based on the pathophysiology, but also based on the medications that we are administering to try and mitigate the seizure activity. And so our initial approach and investigations, and these are general paramedic medical directives that we have in the province of Ontario. We certainly want to support airway breathing and circulation, and we want to recognize when supportive care is required. We want to monitor closely for loss of airway reflexes, respiratory depression, hypotension, and cardiac arrhythmias. And so we want to recognize that patients may require airway suctioning. They may require assistance with maintaining an airway or the establishment of an airway. Physiologic derangements can cause hypotension or cardiac arrhythmias, as well as medication side effects. So it's important to establish early intravenous or intraosseous access. These patients may require a fluid bolus and or fluid maintenance as part of their supportive care. You may need to add dextrose to that fluid maintenance. You want to go ahead and check their blood glucose and temperature checks. We want to recognize that glucose is a correctable cause, as well as a very important substrate for cerebral metabolism. And then you want to evaluate CBC, sodium, calcium, magnesium, phosphate, and blood gases. And in our program, we have an iStat device that can pick up electrolytes. So it's important to identify any of those ongoing issues that can assist in further investigation and provide supportive care. So there's a number of initial interventions that are generally timed. So generally speaking, within the first 5 minutes, we're trying to administer midazolam, and within 10 minutes, we're trying to select a second-line agent, and there are advantages and disadvantages. And these medications certainly aren't in any order. And then for refractory, again, we're looking at additional second-line agents, maybe a midazolam infusion, and then we might be consulting our transport medicine physician for additional options. And this is just right out of our Orange medical directives, and I'm going to pull apart some of these medications just to review. And so concurrent clinical concerns, as you continue with ongoing management of these patients, you probably need to secure an airway, so that means rapid sequence intubation, and it's generally considered safer to do so prior to transport. So you want to really think about expected clinical course, and you want to be thinking about how you're going to properly prepare and package your patient for safe transport. And so in an ideal world, we would like to achieve seizure control and prevention. We certainly want to ensure neural protection is consistently maintained for the transport, and we want to avoid any of the physiologic complications. So the common approach is to induce a coma via rapid sequence intubation. And we've got a couple of different options here within our program. We can use a combination of ketamine and rock, and or midazolam and rock. Now, we generally will use the paralytic agent to facilitate the intubation, but we then will allow that paralytic agent to wear off so that we can continue to monitor for seizure activity. Now, when we look at some of the specific medications, midazolam, There's been several studies that have shown that there's an increase in respiratory depression after 2 doses. One pediatric study showed respiratory compromise as high as 43% with 2 or more doses compared to 13%. So, again, this just sort of reinforces the potential need for and consideration for airway management and or other types of second line medications. Midazolam infusion is really used, I think, for the most part to induce and maintain a coma after the patient has been intubated and mechanically ventilated. Fosphenytoin and phenytoin are 2 medications we carry again in our program as a reminder. Both medications are considered equally effective for managing seizures. Phenytoin is 50 to 80% effective at controlling prolonged seizures. It's got a high pH, and so you have to watch, the medication site for any extravasation because that can cause edema and pain. Fosphenytoin is a very interesting, useful medication. It's water soluble. It's actually a prodrug to phenytoin, and it can be given via IM injection where phenytoin cannot. So that can be a real advantage in the pediatric population if you don't have IV access or you lose IV access. Both of these drugs, phenytoin in particular, can cause hypotension if administered too quickly. And that's more on the phenytoin side compared to the fosphenytoin side. So we're going to move on and we're just going to have a brief look at phenobarbital. Phenobarbital is another second-line agent that can be considered. Recent meta-analysis for benzodiazepine-resistant status epilepticus found that the following efficacy. So they looked at a number of different medications. So they looked at valproic. In particular, phenobarbital was 73.6% successful in cessation of seizure activity, with the lowest medication being phenobarbital. So I think one other consideration, I think what's interesting in terms of how this works is barbiturates such as phenobarbital also inhibit NMDA receptors. Again, there are adverse effects that you have to consider, such as respiratory depression and hypotension. And so clinical considerations here are really making sure that you got your airway equipment out. And a lot of these patients end up being on mechanical ventilators. Propofol we use quite a bit in our adult population for refractory status epilepticus. And I have to say that we do on occasion use it in our pediatric population, but it's generally not listed in the guidelines. And there is one concern where pediatric patients have an increased risk of what's known as propofol infusion syndrome, which is a life-threatening condition caused by rhabdomyolysis, arrhythmias, and renal failure. I have not run into this in my practice as a CCP. For the most part, we're using midazolam infusions, but on occasion we will switch to propofol infusions. Now, the thing here is this situation is associated with doses above 4 milligrams per kilo per hour for durations greater than 48 hours, which is much, much longer than what we would typically have our patients. In fact, our patients we generally only have for anywhere from 2 to 4 hours in our program. Ketamine. In late stages of status epilepticus, there's a decrease in the number of active GABA receptors, as mentioned earlier, within the pathophysiology, and an upregulated NMDA receptors. So research is still limited on this, but there has been a recent review found no randomized controlled trials on this, but they did find 27 case reports, 14 case series. In one of the case series, which included 19 patients, ketamine was successful in seizure suppression in 74% of the patients. So I think there'll be more to follow on this. Levetiracetam or Keppra was just recently the IV form of it brought to Canada in 2019, and the efficacy of this is comparable to phenytoin and fosphenytoin. It may cause less respiratory depression, and it can be administered quicker than phenytoin and has really fewer interactions. So Interrelated to all this, I think it's important for transportation decision making, as CCPs really need to think about and make linkages to expected clinical course. Pediatric patients who are in status epilepticus need to be transported to pediatric centers, essentially capable of intensive care. And your care pathway can have an impact on where you transport your patients. And so, if you make a decision to use some of these second line agents, you need to think about the receiving center. And your decision you make does have an impact on the patient. And so, if you do a rapid sequence intubation on your patient, you induce the patient into a medically induced coma, and you're using second or third line agents, it's important for not only the sending and receiving facilities to know so that they're prepared to accept an intubated, mechanically ventilated pediatric patient, but you also need to inform the parents in the treatment decisions. And so, I think our decisions as CCPs are important in terms of how we manage these patients. So I just thank your time for this quick review on the management of refractory pediatric status epilepticus.